Hello, everybody. My name is Jeehoon Kang, and I'm the JACC Asia Pulse Specialty Content Editor. And this is one of our JACC Cardio-Onc series that we're having. Today, we have Dr. Choon Ta from Singapore for the case presentation, and we have Dr. Shen from UCLA and Dr. Park from Seoul National University Hospital as our panelists. For no further delay, Dr. Choon Ta, could you start your presentation?
Hi, my name is Choon Ta. I'm a cardio-oncologist based at the National Heart Centre, Singapore. Today, I'll talk about how do we diagnose and treat immune checkpoint inhibitor myocarditis and what every cardiologist needs to know. ICI have actually transformed the treatment and improved prognosis in oncology, but they have also introduced multi-systemic immune-related adverse events. Today, we'll explore a real clinical case of a 72-year-old female with esophageal adenocarcinoma on pembrolizumab. She has a known history of poorly controlled diabetes and was started on pembrolizumab by her oncologist. And the way I recognize whether it's an immune checkpoint inhibitor is that usually ends with MAB, stands for monoclonal antibody. Around 28 days after initiation of treatment, she actually experienced 4 days of lethargy, lower limb muscle ache, weakness, as well as dyspnea and exertion. These are relatively non-specific symptoms that an oncology patient would experience in the course of treatment. But what's unusual is that this patient actually had one episode of syncope, and there was no preceding chest pain. The presence of syncope is a sinister sign, and we should take it very seriously. Most of the ICI myocarditis cases occur with a mean of 34 days after first exposure. It can be divided into early onset as well as delayed onset. On clinical examination, we see this female with bilateral ptosis. There's a lot of forgettability in terms of her eyes. While talking to us, her eyelids kept drooping down. The blood pressure was stable at 118/70 mmHg. But what was interesting was that her heart rate seems to fluctuate between 42 and 148. This heart rate variability from bradycardia to tachyarrhythmias suggests some form of arrhythmias or even electrical instability, for which we'll look at the ECG in a short while. Auscultation revealed a Garrett rhythm. At examination, you do note that there's bilateral pitting pedal edema as well as an elevation of the JVP. Of note, there was a reduction in the power of the lower limbs of 3:5. Previously, she was able to walk, and she claimed that over the past few days, she felt weaker and she had to rely on a wheelchair. We did an ECG for this patient, and as you can see, it's a very wide complex tachycardia, or rather that our concerned that it could be a slow VT or ventricular tachycardia. When we repeated the ECG in a short while, it actually showed transient high-grade AV block with ventricular escape. As you can see from this ECG, there's complete PQRS dissociation, and there's actually ventricular escape rhythm as well. There's also ST elevation in the inferiority that you can recognize. Laboratory investigations. The most common investigations done in the setting of a patient whom we suspect to have cardiovascular issues would be that of an anti-proBNP, a troponin, and in ICI cases, I will routinely do a creatinine kinase. In this patient, the anti-proBNP was elevated at 1019. That was 9 times the upper limit of normal, and the troponin I actually showed a progressive rise, whereas the creatinine kinase was also elevated 10 times above the upper limit of normal. This combination should immediately raise the thought of some form of myocardial injury, be it acute coronary syndrome or some inflammation of the myocardium like myocarditis. And the CK elevation tells us that not just myocardium is affected, there's also some skeletal muscles involvement that actually fits into a clinical scenario of bilateral leg weakness. If we were to compare between the troponin assays, troponin T versus troponin I, if you have access to both agents, troponin I is actually more specific for cardiac myocytes, and that is the troponin of choice that we order when we suspect ICI myocarditis. This patient went on to have a coronary angiogram, and the reason why this patient had coronary angiogram was because of the presence of ventricular arrhythmias. There's also some ST elevation in the inferior leads that we saw previously, and it turned out to be normal. The echo showed a reduced ventricular fraction of about 43% with reduced GLS, and a few days later, this patient managed to get a cardiac MRI that showed the presence of LGE enhancement in a non-ischemic distribution, as well as the presence of myocardial edema in T2's weighted sequences. At this point in time, let's pause. When should we pursue coronary evaluation, and why does it matter? Routinely, it's suggested that we exclude acute coronary syndrome before we make a diagnosis of myocarditis, especially if the presenting symptoms are ACS-like. For instance, if there's ventricular arrhythmias, when there's chest pain, and patient characteristics. If patient is at risk for coronary artery disease, of course, an ECG that is suggestive of ischemia should warrant a coronary evaluation. And ICI has also been recognized to cause accelerated atherosclerosis. They can cause arterioma, high-risk lesion, increase blood progression, as well as instability, leading to things like thrombosis, as well as myocardial infarction. Given that the coronary evaluation was unremarkable and the MRI findings were suggestive, a diagnosis of immune checkpoint inhibitor-related myocarditis was made. And this was subsequently revised to a immune-related adverse events triple M syndrome, where M stands for myocarditis, N stands for myositis, and M for myasthenia gravis. And this is a syndrome or phenotype that actually has very poor prognosis and high fatality rates of 50% or so. It's extremely important to recognize and initiate treatment in this group of patients. If you look at the phenotypic expression of patients with just isolated myocarditis versus those with triple M syndrome or myocarditis myopathy overlap, there are some differences. For instance, in terms of the laboratory values, in patients with isolated myocarditis, they usually have a higher NT-proBNP, they have higher incidence of reduced ejection fraction, and also higher incidence of acute heart failure symptoms. For instance, leg swelling, autopnea, paroxysmal nocturnal dyspnea, and events such as hospitalization for heart failure. But in the other group of patients with overlap syndrome, usually they present as very high troponin I and T, high creatinine kinase, elevated AST, ALT. The ejection fraction can be preserved in this group of patients, and they usually or sometimes have a higher incidence of ventricular arrhythmias as well as high-grade atrial ventricular block. So let's move on to how should we diagnose ICI myocarditis. This is the ICOS 2022 criteria. When there's clinical suspicion of ICI-related myocarditis, initial tests will include your troponins, your ECG, your echocardiogram. In patients with fulminant myocarditis, a histopathological diagnosis via a endomyocardial biopsy is recommended if you have access to that and is available to you. A clinical diagnosis can include a change in troponin plus one major criteria or two major criteria. The major criteria is that of MRI criteria based on the modified Lake-Lewis criteria based on non-ischemic injury that's T1 based, the presence of myocardial edema, and supportive criteria, for instance, LV dysfunction, pericardial effusions. Minor criterion include clinical syndrome, for instance, very non-specific, such as weakness, fatigue, myalgia, ptosis, diplopia, leg swelling, palpitations, syncope, cardiogenic shock. A decline in LV function, the presence of other immune-related adverse events, for instance, like myositis, myasthenia gravis. So this summarizes the clinical histopathological spectrum of ICI myocarditis diagnosis: the clinical syndrome, the use of echo, the use of cardiac biomarkers, ECG findings. For instance, you get PR prolongation, you get QRS widening, you get heart block, you get ventricular arrhythmias, and MRI findings, the presence of weight gap enhancement, as well as histopathological findings. In patients with ICI myocarditis, majority will have troponin elevation, ECG changes, more than half with a drop in ejection fraction, and more than 3/4 will have an elevated NT-proBNP. And what are the risk factors for ICI myocarditis? Firstly, pre-existing cardiovascular disease, patients of presence of diabetes mellitus, heart failure, acute coronary syndrome. Tumor subtype, usually the renal cell, the lung carcinoma, as well as melanoma have a higher risk, more common in females, and more common with ICI combination therapy. For this patient, she was actually treated with 1 gram of methylprednisolone for 3 days, and intravenous immunoglobulin or IVIG for 3 days as well because of myasthenia gravis at the advice of our neurologist, followed by steroid taper for 6 weeks. The high-grade AV conduction block actually resolved very promptly after 3 days of IV methylprednisolone. Subsequently, when we repeated the echo, at 4 weeks, there was an improvement in ejection fraction to 49% from 44%, and subsequently, by 2 months, it normalized. So this shows a timeline of what happened. Day 1 of pembrolizumab, the side effects occurred around day 28. If you recognize from literature, the mean onset will be around 34 days for the effects of ICI myocarditis. And this patient had relatively non-specific symptoms of lethargy, shortness of breath, but syncope is something that should raise suspicion. Promptly, this patient was started on IV methylprednisolone, followed by oral pred taper. After 3 days of IV methylprednisolone, there was resolution of AV block, and subsequently, by day 60, there was actually an improvement in ejection fraction to 40%, and it normalized to 56% by 8 weeks. In terms of the general guidance for ICI myocarditis, this is usually a grade 4 adverse events. And as with any grade 4 immune-related adverse events, we should permanently discontinue ICI, initiate corticosteroids, taper over 4 to 6 weeks, and consider other forms of immunosuppression if steroid refractory, as well as supportive treatment. This provides an overview on the management of patients with ICI myocarditis. The first is to assess the severity, whether it's fulminant versus non-fulminant. For fulminant cases, these patients will need to be admitted to a high dependency unit or a ICU, and for supportive treatment, and that may include, for instance, pacing wires in the setting of high-grade AV conduction blocks. It can also include things like ECMO support. In patients in general with myocarditis, importantly is to discontinue ICI, and start IV methylprednisolone 500 mg to 1000 mg if there's no obvious sepsis on board, if the clinical suspicion is high. Often we start even before we get a cardiac MRI, as early initiation of treatment is important. And patients who recover can be switched to oral steroids after 3 to 5 days of pulse methylpred. Whereas for patients who are steroid refractory, we can consider the second-line agents. And what this means is that if the patients do not respond clinically, which means they still have heart failure symptoms, their ventricular arrhythmias or heart block is getting worse or not improving, or biochemically their troponins continue to go up and it's not reducing to the extent that we want to see, should consider another agent. In conclusion, the 3 take-home points that I have is that, firstly, when you suspect patients with ICI myocarditis, think beyond the heart, because the patient may have weakness, may have ptosis, may have a more systemic form of immune-related adverse events. Secondly, the use of biomarkers and multimodality imaging. Biomarkers such as CK, creatine kinase, troponins, NT-proBNP are important, and imaging modalities such as cardiac MRI, echo, as well as ECGs are useful to help us in the diagnosis. Very importantly, time is myocardium. The early diagnosis and treatment is very critical for the recovery of patients in myocarditis, which carries a mortality of 30 to 50%. With that, I thank you for your attention and look forward to the discussion. Thank you.
Thank you, Dr. Choon Ta, for your nice presentation. Now we will have some discussions. And does anybody have some questions about this case?
I really like this case, especially because it shows how rapidly ICI myocarditis can evolve. I had a very short comment and a question focusing on the ECG, since it's often the very first test we have in real-world practice. In this patient, I was wondering about the QRS voltage, especially in the limb. It may not be very strikingly low here, but this patient did have extremity edema, which by itself could contribute to reduced QRS amplitude. That said, in patients receiving immune checkpoint inhibitors, other mechanisms can also be relevant. Beyond edema, we often think about pericardial effusion or myocardial edema, similar to what is seen in Takotsubo cardiomyopathy. In this case, the echocardiographic images don't suggest a large pericardial effusion, whereas CMR showed myocardial edema, which makes myocardial edema a possible plausible contributor. So even if the absolute voltage isn't dramatically low, a new reduction in QRS voltage compared with a prior baseline ECG might be an important early clue. So my question is, in your experience, what ECG findings do you consider the most important early red flags for ICI myocarditis, and how much weight do you place on conduction disturbance, tachyarrhythmia, atrial ventricular or something, PR prolongation, STT change, QRS change, QT prolongation, or low or newly reduced QRS voltage when deciding to pursue urgent further testing?
Hey, thanks, Dr. Park. I think that's a very good question. I mean, as cardiologists, we have access to ECG. I think the learning point for this is that all patients prior to treatment, especially for immune checkpoint inhibitors, should actually have a baseline ECG done, because that will allow us to compare what happens after that. As you rightly mentioned, in some patients, there can be reduction in QRS complexes because of the presence of myocardial edema, because of the drop injection fraction. A few things we look at on ECG. One is the usual things that we look for instance, STT segment changes. In this patient, the patient did have ST segment changes in the inferior leads. There were some T wave inversions in the ECG as well. That actually prompted us to pursue a coronary angiogram to exclude a coronary artery disease, because ICI does not just cause myocarditis. It has been shown to accelerate atherosclerosis and cause acute coronary syndrome, like ST segment elevation, myocardial infarction, and this is potentially treatable. In most patients with cardiotoxicity secondary to any chemo agents, in any immunotherapy, one of the earliest signs that we actually notice is actually the fact that QTC interval can be a bit more prolonged. The QRS can be a bit widened. So this can be the earliest sign of some form of myocardial toxicity. In this patient, I mean, he presented with syncope and it really had a high-grade AV conduction block. Also, the patient had ventral arrhythmia. So you know that there's definitely a lot of electrical instability going on in these patients. Other things that we look out for is actually that our pericarditis changes can occur with ICI, less common, less than 1% of patients. I think by and large, these are things that we look out for in patients with immune checkpoint inhibitors. So to summarize, early signs include PR prolongations, QTC prolongations. The more advanced findings will be that of conduction defects, like ventricular arrhythmias or even high-grade AV conduction blocks.
Thank you for your helpful response. I understand it very well. I think maybe AI might be helpful for us in the future as well.
Choon Ta, thank you so much for this fascinating case. It's a great honor to have you here. My question is regarding the second-line treatment options for ICI myocarditis. The patient in your case had a great recovery with the IV steroids alone. If in other cases where patients are having minimal response to steroids, what are some other treatment options? And to give you some context for discussion, where I'm training, typically we're seeing that a beta-CEP, which is a CTLA-4 fusion protein, and ruxolitinib, which is a JACC inhibitor, are being used. And there's some literature that showed these two agents might have synergistic effects. And sometimes we also reach for things like ATG, antithymocyte globulin. So I'm just curious, at your center, what are some treatment options used? And what is your approach to picking which second-line agent to start for different cases?
Okay, thanks, Dr. Shen. I think that's a very loaded question. So when we decide second-line agents, the question is, when do we consider them? We consider them if there's no response to the initial steroid treatment. We consider them if there's no clinical improvement, no improvement in terms of troponins or biomarkers. In terms of the choice of second-line agents, I mean, it really depends on, firstly, what's available in your country. I think you mentioned abatacept as well as JACC inhibitors. Unfortunately, we do not have that in our local context. That also depends on what other immune-related adverse events the patient has. For instance, in this patient with myasthenia gravis, the neurologist actually suggested intravenous immunoglobulins that will help with both the myocarditis as well as the myasthenia gravis. What we have tried in some other cases would be that of plasmapheresis as well, especially there's myositis, there's myasthenia gravis as well. The common agent in isolated ICI myocarditis, if we just have to make a choice based on cardiology, the cardiac side effects would be, for instance, things like mycophenolate mofetil or CellCept is an immunosuppressant that helps to suppress the immune reactions. And we also tried IL-6 agents such as tocilizumab as well. So all the different agents, in terms of the response, it really depends on what other immune-related adverse events the patient has and availability. I agree with you in terms of abatacept, it seems to be the most promising agent. There's an Atrium trial that's ongoing that hopefully will get the results soon that will help guide management. And really, when you start a second-line agents, the aim is to firstly see how it responds and to try to win down the steroids as well. Because a lot of times when you have steroids with second-line agents, there's a lot of adverse steroid-related effects. So we try to start a second-line agent, and once it works, we try to win down the steroids. I hope that answers your question.
Yeah, thank you so much for explaining that and your insights. It just shows that these cases are so complicated because ICI myocarditis is affecting the heart, but people at the same time, they have neural manifestation and other organs. So picking the treatment options is also a complicated decision. And with different options available in different countries, this is a very interesting topic. Thank you.
Yeah, maybe I'll just add on. I think this also provides an opportunity for us to interact in a multidisciplinary approach with other subspecialties. For instance, we have an immune toxicity group in Singapore whereby we have dermatologists, nephrologists, neurologists, oncologists, a whole host of different people from different subspecialties to provide different input. And having this multiple input allows us to best manage the patient because this patient does not just have a cardiac issue. I mean, myasthenia gravis can be devastating as well. They might require ventilatory support. Yeah, so I think a multi-D approach is preferred in this group of patients, and there's no evidence-proven secondary agents, and there is also a need for more research in this area.
Yes, thank you, Dr. Choon Ta, for being with us. And my last question might be slightly a very practical question. Let's say that your patient, the metastatic esophageal adenoCA patient, had a very nice response to this pembrolizumab, and the patient needed further treatment to consider a resolution of the cancer. Would you try to re-challenge this agent, or is there any literature explaining how to do further treatment for these patients?
Okay, thanks, Dr. Kang. I think that's a really difficult question that we have because when they respond to treatment, the patients do have hope, and when I tell them that you cannot have this treatment anymore, they feel dejected. So in terms of the evidence for re-challenge is limited. In this particular patient, because of the fact that the patient had triple M syndrome, had a really fulminant myocarditis, I probably wouldn't suggest a re-challenge because when you re-challenge because of immunomemory, they get a more severe form of myocarditis and more severe symptoms. However, in patients with milder form of myocarditis, there have been case reports coming up about re-challenging patients with ICI, maybe other types of immune checkpoint inhibitors. And the general principle is that all this should be via a careful, deliberate process of multidisciplinary discussion. And if there's really no other options, then we consider re-challenge at very high risk. And in these patients that people have re-challenged, they usually have very close surveillance. For instance, they monitor their troponins, they monitor their ECG very routinely after re-challenge. And the moment these patients develop some form of cardiac toxicity, they actually treat them very aggressively. So it has been done, but re-challenge is really tough. It should be reserved for when there's no other options. It should be only after careful deliberation process with both the patients, the team looking after the patients. And if you do re-challenge, really monitor this group of patients very carefully, biochemical markers, your ECG, and treat them. The first instance, they have some form of adverse events or side effects.
Thank you. Thank you for your nice response. So are there any further questions, just asking? No, then well, thank you for your time, and thank you for being us. And well, our audience are early career cardiologists, so you might get some context by them. If you do, just appreciate the contact.
Happy to.
Okay. So we will end this session right now. Thank you, everybody.
Okay, thank you very much.
Thank you.